Dear students, welcome to Game in Pathology. When I introduced the channel Game, I meant gross and microscopy explained. But today, it encompasses the entire pathology spectrum, both for undergraduates as well as postgraduates. And in this, urine analysis plays a vital role. This class is mainly intended for the undergraduates. The postgraduates shall be visited later with more details. Coming back to this urine analysis, students should realize that it is a major practical exercise. It can be asked in the viva essay also. MCQs are not spared. Theory, it can come as a short note, such as hematuria, proteinuria, so on and so forth. And some of the instruments which are used in this can be kept as spotters. So you people can estimate the importance of this topic, and I'm taking part 1, which means part 2 or part 3 should be visited by you people. Collection of urine. Students directly have a tendency to go to the Benedict solution or for the protein test. But they should realize that marks are being allotted for the physical examination, coming to a diagnosis, performing the clinical experiment, as well as answering the questions the examiner asks. So, collection of urine. There are various samples of urine that could be collected for a test. The early or the first morning is for routine urine examination as well as pregnancy test. If the sample is given in the afternoon, a pregnant woman might show a negative test. Random and midstream, again for protein. Clean catch. The genitalia are supposed to be cleaned and then separated, labia. Finally, a midstream urine is collected. The first part of it is not collected and the midstream alone is conducted into the containers. This is mainly for culture and sensitivity. Postprandial. It can be for glucose and urobilinogen. 24-hour urine for certain tests such as proteins. What is the 24-hour protein? Or for hormone assay. Sometimes I also introduce it for tuberculosis. Catheterized samples for infants and bedridden patients. Suprapubic puncture. Again, if the patient were to have a bladder paralysis, urine will not be there, but it will be collected in the bladder for proteins and hormones. Plastic bag or a colostomy bag for infants and incontinent adults. So look at the various samples. I would like you people to by heart this and answer. Be clear with your subheadings. Subheadings are subheadings, they take us to the answer. And these are the subheadings, kindly go through them. I would concentrate on the picture as such. Urine as such, I'll be defining later. So this is the glomerulus. The glomerulus itself is a tuft of capillaries. And I find the major arterioles entering, dividing into capillaries, and that tuft forms the glomerulus. And there is a capsule surrounding it called the Bowman's capsule, which empties into the tubules. So there are the various tubules, you people know. The proximal and then the loop of Henle, the ascending tubule, etc. Finally, you have got a collecting duct which collects from various tubules and enters the pelvis. What are the indications for urine analysis? I've already shown you in one of the first topics or slides, but then here Urine analysis can be a routine test for anyone. Whenever a patient enters a hospital, he is being asked to do a routine hemogram, a basic biochemical test, and routine urine analysis. It can be done for renal diseases, particularly glomerulonephritis, nephrosclerosis, pyelonephritis, renal failure, etc. Urinary tract infections, diabetes, no test without urine, hematuria, jaundice, pregnancy, for malignant cells, plasma cell dyscrasias. And coming to the definition as such, urine is defined as an ultrafiltrate of the plasma. In other words, it is literally blood that has been filtered, ultra-filtered, and it comes out as urine. The various samples I have mentioned in the enclosure for you people to memorize. Physically, volume is one important characteristic. In the normal volume, urine is about 600 to 2000 ml. It varies, and the average can be 1000 to 1200 ml per day. Polyuria is a marked increase, persist 2000 or above. It can be physiological, such as in a case of increased fluid intake, obviously. Temperatures. In cold weather, you find that there can be a frequency of urination because there is no sweating. When the patient is on diuretics. So all these will be causing a physiological polyuria. There can be pathological also, which can be diabetes mellitus, diabetes insipidus, and in chronic renal failure. Renal failure, you might think that there will be no urinary output, but then there will be a stage of oliguria and a stage of polyuria as well. Oliguria, this is important. What is oliguria? When the total urine output is less than 400 ml per day. All these questions will be asked in the viva or during the practicals when the examiner comes to you. It can happen in dehydration, sweating, and in acute renal failure. In hot weather, in increased sweating, you find that the urinary output is obviously reduced. Anuria. Anuria literally means absence of urine, but then less than 100 ml is construed to be anuria. This can happen when there is a near total obstruction or when there is a nerve dysfunction. As I mentioned earlier, the bladder will be inflated with urine, but there will be no urinary output. An ice quote, smell is a potent visitor that transports you across thousands of miles and all the years you have lived. Helen Keller, a person who has lost important senses. And what is the order of urine and its importance? Some books give it as pleasant. I will not agree with that. So I mentioned it as not unpleasant when freshly voided. But on standing, it develops an ammoniacal decomposition and a worst sample. Fruity when there is ketoacidosis or starvation. Musty odor in phenylketonuria. Fishy, foul, and ammoniacal in urinary tract infections. These things you people should by heart. As I mentioned earlier, I generally give my students 40% marks for the physical examination, 60% marks for the chemical examination. Color. Again, a shade of colors is given over here. Look at the different range of colors you can get in urine examination. Color is different from appearance. We shall go to appearance later. A patient can come with a white urine. It is a very practical example that I had faced. I had asked the urine to be collected by a patient. He brought it in a test tube. It was a male patient. It was white and starch-like. I said, no, this is not the sample. You should collect urine. Again, he came after some time. It was similar. And then we realized it is chyluria. Chyluria is nothing but lymph. And this can happen when a patient is having filariasis. Pale straw-like color when there is overhydration. When it is diluted, it becomes very pale. Even the straw color is not obvious. It becomes darker yellow in the case of dehydration and on administration of B complex. Very deep yellow in jaundice. Orange colored in rifampicin. It can be quite frightening. In fact, we had been advised to warn the patient about this particular color and not to panic. Cola colored in glomerulonephritis. This will be a classical history. Post-streptococcal glomerulonephritis, the patient passed a cola colored urine. Pink colored is hemoglobinuria. Hemoglobinuria is different from hematuria. We shall be seeing it. Green colored, again it is infection, but it is due to Pseudomonas. And red colored, it can be hematuria. So these color changes, I would like you people to by heart. I had given a specific list for undergraduates. Appearance is what we see. It is a little different from color. Normally, you find that the urine is clear. You will definitely agree with me that this urine sample is not clear. I am not able to see through it. Courtesy Wikimedia. And this is a beautiful example of a cloudy urine occurring in urinary tract infection. And sometimes it can be because of some precipitate also. And it seemingly appears to be turbid, but on settling down, the urine itself is clear, but then there is a sediment. These people should be able to differentiate. I hope you have understood the difference between color and appearance. A cloudy appearance whenever there is infection because of the pus cells. Pink and cloudy because of urates. Red colored, it becomes clear on standing because of hematuria. RBCs will be settling to the bottom, therefore you get a clear color. Flocculated because of heavy proteinuria. So these are the appearances of urine. The preservatives for urine. First and foremost is refrigeration. If the sample is going to be kept up to 8 hours. Beyond 8 hours, even refrigeration is not recommended. Normally, it is advisable to do the urine test within the first 1 hour. Refrigeration is at a degree of 4 to 6 degrees. Chemical preservatives are hydrochloric acid for hormones such as adrenaline and vinyl mandelic acid. Toluene for chemicals. Boric acid. Thymol, it inhibits the growth of organisms. And formalin for all chemicals. So this will be the list of preservatives you people should give, and I've also written it in my record. And why should you do within 2 hours? Because of the decomposition, the precipitation of unnecessary crystals, and so on. Also, there will be the growth of the organisms. The enzymes will become degenerated. So we will have to do it as early as possible. Varley, a superb author in biochemistry, has said the urine is the mirror image of the kidney. And one of the factors that will be essential will be the specific gravity. There are 3 methods for measuring the specific gravity. 1 is urinometer, 2 is refractometer, and 3 is the reagent strip. Urinometer, the principle is buoyancy or floating. 50 ml of urine is required, and the lower meniscus is taken as the reading. Refractometer, 1 to 2 drops will be sufficient, which is displayed on a screen. And the principle is the refractive index. In reagent strip, there is a change in the indicator, the bromothiamol blue, and it measures the ions in the urine. So these are the different methods you people should be mentioning it. And what is the significance of the specific gravity? You find that the range is there, 1.016 to 1.022. And the specific gravity increases with solute concentration. Solute is the material that is there, and solvent is the one that dissolves it. Both together form the solution. It is increased hyperestheneria, and It occurs in glycosuria or albuminuria. The proteins are increased, sugar is increased. Decreased, hypostenuria in a case of diabetes insipidus, or sometimes in overhydration. Fixed or isosthenuria, which is the end stage renal failure, because the kidney is neither able to concentrate nor able to secrete. The urinometer is an important instrument and test that will be given to you people. It is consisting of the urinometer. This is the urinometer, and then a jar is correspondingly provided. It can have fluid up to 100 ml. What happens is the patient's urine is collected in this jar. Generally 50 ml will be adequate, and the urinometer is made to float in it. The lower meniscus is taken as the reading. There is always a correction for it. For every 3 degrees less in the temperature, you will have to add 0.001 to the specific gravity. For every 3 degrees more, you will have to reduce 0.001. The normal volume that is required is about 50 ml. But if the patient is passing only 25 ml, then 25 ml of distilled water is added, and the specific gravity that is obtained is finally multiplied by 2. There is a correction in this range. And there are also alternate methods you people should be knowing. So there is a bulb over here, and then the neck with the graduations. This is a jar. There can be a dark colored urine. Dark colored urine you can get in some conditions. One, what we are seeing over here is rhabdomyolysis. This is a normal urine given for comparison, but here the patient is passing a brownish black colored urine because of rhabdomyolysis. The other things you people know, hemoglobinuria. Whenever there is a lysis of the RBC, you get a dark urine. Black water fever in a case of cerebral malaria. Alkaptonuria, phenylketonuria. The urine is clear, but then it turns black. Phenylketonuria. So these things you people will have to by heart and say, when do you get a dark colored urine or a black colored urine? The pH is another important factor. It can vary from less than 7, which is acidic, to more than 7. And the causes for the variation will be diet, the amount of water intake, the function of the renal tubules. Acidic urine generally we get in ketosis, starvation, E. coli infection, or in citrus foods. That is vitamin C, it contains ascorbic acid. Obviously, it will be acidic. Alkaline, in a vegetarian diet, vomiting, urinary tract infection because of protein spilling bacteria. Proteus, Pseudomonas are the examples. So you can get acidic urine, you can get alkaline urine. The significance is you will know the tubular function. And the indicators are bromothymol blue and methyl red. These are the two indicators. And look at the range over here. This will be provided. You dip the dipstick in the patient's urine sample and you compare it with the comparators. These are all the comparators and the significance is given over here. pH. So please memorize all these exercises you will be expected to do. So this is a slide about the dipsticks. So there is a stick with a range of these indicators and it is completely immersed in the urine sample and a corresponding reading taken. In an alkaline medium, you find that. This is the one. Bromothymol blue is being converted to a blue, from a blue color to bromothymol blue minus H plus, which is yellow in color. So this is the basic principle of the dipstick. They'll be asking you, what is the principle of the dipstick? Bromothymol blue is being converted to bromothymol yellow. And all these parameters can be diagnosed by means of a single dip. Protein, glucose, bilirubin, urobilinogen, acetone, nitrite, leukocytes, pH, hemoglobin, and specific gravity. We used to call them a 10-part dipsticks. And what are the uses? It can be used for screening generally. for self-monitoring. Supposing the patient is perennially sick, it can be self-monitored, and also to judge the response to treatment. So these will be it. This is called the strip method. So after the physical examination, obviously you have got something called the chemical examination. In this chemical examination, all these parameters are to be there, but a few are restricted to the undergraduates, of which I shall be seeing proteins alone in this class. The others will be the glucose, ketones, and blood, and perhaps bilirubin. What is proteinuria? Again, coming back. So this is the glomerulus. As I told you, this is the capillary of the glomerulus. The blood enters. This is a gray color is the basement membrane. You have got an inner cell. So this is the glomerular endothelium. This is the glomerular epithelium. And normally what happens, there is no leakage across over here. Most of it goes into the tubule. But sometimes what happens is, you find that there can be a leakage of proteins resulting in proteinuria. So this can happen because of the increase in the fenestrations, or sometimes leakage across the basement membrane, or some damage to the epithelial foot processes. All this can lead to a proteinuria. This again is a beautiful diagram, courtesy labpedia. This particular series, if you people can get onto, it is useful for educating yourselves. So this is the glomerulus, a tuft of capillaries. This is a filtrate, and then it is being taken into the tubules. Finally, it is being excreted. So in this one, what happens is, this is again the blood. Part of it can be reabsorbed. In fact, most of it is being reabsorbed. Your urine passes into the tubules, but it is getting reabsorbed. It goes back into the blood. Only when it is in excess, it gets secreted. So this is the band. Finally, excretion. Excretion is supposed to be the nitrogenous waste products that are removed from the body. The glomerular filtrate, it can be containing all these substances. And protein, this is the one. These shall be dealt with in the subsequent slides. I hope you people are able to understand the principle of the glomerulus and the tubule, the reabsorption, secretion. Proteinuria. Whenever there is an excretion of protein more than 150 milligrams per 24 hours, it is defined as proteinuria. There is a range between 10 to 150, which is not measured by the usual methods. So this is considered to be normal. Secondly, the proteins with a low molecular weight, they alone are able to permeate the glomerulus and come. The rest are being reabsorbed. This is called as selective proteinuria. Low molecular weight proteins alone are being precipitated or removed. Non-specific, on the contrary, both low molecular weight and high molecular weight proteins are being excreted. So this is important. That means the glomerular function is failing. This is proteinuria. And definitely one question will be asked, what is microalbuminuria? Microalbuminuria means it can test even 30 to 150 milligrams per day. This is also albuminuria only, but as I told you, the normal test will forego this. There is an increase in the microalbumin in the case of early renal disease and in diabetic patients. Less than 150 milligram not detected by the usual methods. Please by heart this chart. Proteinuria, there are various causes for it. One can be physiological, which can be exercise, postural, pregnancy, overflow, hemoglobinuria, multiple myeloma, myoglobinuria, so on and so forth. Look at this one. Let us see what happens. Normally, you find that there is hardly any protein that is entering the tubules. Sometimes there can be an overflow from the glomerulus into the tubules. It is getting reabsorbed. It can be in a case of myoglobin. Sometimes Bence-Jones proteinuria can be found by this method. When there is going to be a glomerular damage, there is an albuminuria. And when it is minimal, there is something called as microalbuminuria. And there are some other diseases where the kidney is normal, but there is a post-renal albuminuria. For example, in the renal pelvis up to the bladder, there can be damage, infection, so on. So these are the various causes, and there is a beautiful diagram explaining the principles of it. Physiological proteinuria. Dear students, what are we seeing on the screen? This is a test that we are routinely doing. This is a test tube, and 2/3 of it is being filled with urine, and the upper part is being heated. On being heated, I find that there is a precipitate that is getting formed in the upper portion. Why is the test being done like this? I would like you people to answer. In fact, this will be asked. And second one is, how do you do this test? Most students say that it is by using a test tube holder. On the contrary, I find that the test tube is being held with the hand, and there is a turbidity that is developing on the top. It is being held with the hand so that the change in the temperature could be felt. Secondly, there is a turbidity at the top which can be compared with the clear urine sample at the bottom. So even a mild proteinuria can be made out, the Bunsen burner and this. So, and look at the range over here. So this clarifies what I have said. So this is a normal urine sample. Here there is a mild amount of precipitate which gradually gets intensified, and here it becomes thick and curdy. So range of proteinuria is given over here. The sulfur salicylic acid method. The heat method, how do you grade the proteinuria? Always when you answer, you will be asked the grading. So there is trace which is hardly visible. We used to say you should have a printed material behind the test tube. So if you are able to read it, it is clear. If it is barely visible, then the precipitate is occurring. 1+, cloudiness, no flocculation. 2+, granular cloudiness, no flocculation. 3+, dense cloudiness with flocculation. And 4+ is thick curd-like coagulum. So this will be it. In the last grade, we can even invert the test tube without the contents falling off. Heat test. This is how it is being performed. And the cloudiness, if it is due to phosphates and carbonates, it disappears. When we add acetic acid, you are supposed to add 2 to 3 drops of acetic acid. If it is due to other than proteins, they will disappear. If it is albumin, it is persistent. Heating and disappearing on cooling, it is BJP. It is not Bharatiya Janata Party, it is Bence-Jones protein. Sulfur salicylic acid is another one. The procedure and the principle are given over here. Please read it. And this is the way we grade it. 1+ to 4+. And 1+, it indicates 10 to 50 milligrams. 2+ is 50 to 200 milligrams. 3+ is 200 to 500. And 4+ is cloudiness with precipitation more than 500 milligrams. So this will be the grading. So like students, the proteins also have got grading. How many of us have felt that the examiner has not given us enough marks or the marks that we deserve? So this is the answer for it. I began clearing the dishes off the table, subtly informing my guest that it was time to leave. The key word here is subtle. When there is something that is unnoticeable, the examiner notices it, and that makes the difference in the marks. So always try to read in between the lines so that you are impressive even with the most difficult, unexpected questions. I like songs with a lot of feeling of subtlety. Look at this one over here, sulfur salicylic acid. I hope you people are able to identify where the precipitate starts and where it ends. Ending is obvious, but then where it starts, you people can make out by yourself. Look at this one, trace 1 plus so on till 4 plus. The grading, I would like you people to answer. Definitely, I will ask you in the exam. The Heller's test is another test. The urine is added to concentrated nitric acid drop by drop, and the protein is precipitated at the junction. It is present as a white ring. So in this case, when it is negative, it is absent. Here I am able to see a white ring. That is Heller's test. There is something called as transient proteinuria because of exercise, urinary infection, febrile illness, congestive heart failure, menstruation, sometimes even in diabetes or in blood pressure. So there can be a transient. When these are controlled, you find that it becomes negative. Esbach's albuminometer. This is another one for 24-hour protein. There is a 24-hour protein that is being there. And this instrument is called the Esbach's albuminometer. So here what happens is it is graduated. There is a U mark and then there is an R mark. Up to the U mark, the urine is filled. Then the Esbach's reagent is added. It is inverted and then the rubber cork is fixed. It is inverted and then placed in a mobile position, rather a stable position for a period of 24 hours. After that, you find that the precipitate gets settled down and I can make a reading. This is called the Esbach's albuminometer. And why is it yellow in color? Because it contains picric acid. It is called albuminometer mainly because it measures albumin. This can be kept as a clinical case for you, after which the urine sample will be given. So, various glomerular causes for proteinuria, it can be nephrotic syndrome, glomerulonephritis, IgA nephropathy, all these come under nephrotic syndrome itself. And look at this child, there is a puffiness of the face and then there is a swelling around the eyelids. So, and you find that hands and feet also will be showing an edema, generalized edema called as anasarca. And please do not separate practicals and theory because one can help the other, correlate and get more marks. They are the heart and soul of each other. And this is the summary of it. Glomerular causes, I told you earlier. Secondly, it can be diabetes and SLE. Tubular causes, after the glomerulus is the tubule. It can be hypertension, drugs, nephrosclerosis, acute tubular necrosis. The Bence-Jones protein. Here I find that there is no elevation, whereas in the second one, in the case of myeloma patient, there is an elevation because of the formation of the M protein. This is a normal lymphocyte. When there is an exposure to an antigen, a plasma cell is being formed. The plasma cell produces the immunoglobulin. In a case of multiple myeloma, you get the kappa and the lambda chains, which will be diagnosed. That is the Bence-Jones protein. It can be diagnosed by various methods. The counterpart of it will be the bone marrow showing the plasma cells. Go back to my chart as well as the theory on myeloma, you will be able to understand more. For diagnosing a multiple myeloma, these are all required. One is the bone marrow for plasma cells, ESR more than 100, serum calcium is increased. X-ray will be showing punched out lesions. Bence-Jones protein, electrophoresis, urine as well as the serum. This is how the Bence-Jones protein is done. You will be asked and you have to answer. At room temperature, this is how the urine appears. On heating, between 55 to 60 degrees, there is a precipitate. Further heating to 100 degrees, it disappears. On cooling, it reappears. And at room temperature, it disappears. So this is the Bence-Jones protein. And one question I ask the student is, how do you heat? How do you know that the temperature is 60 degrees or 100 degrees? It is kept in a water bath and the temperature adjusted. So the methods of identifying the Bence-Jones protein will be all this. Go to R.A.T.S for details. So this is a beautiful one. I would like you people to again recollect What is the glomerulus doing? What is the tubule doing? What is the reabsorption? How it is going back to the blood? And what is the glomerular filtrate, which is the albumin mainly. The glomerular causes, nephrotic syndrome is the main one. All the components of nephrotic syndrome you should mention. There can be secondary nephrotic syndrome in a case of diabetes, amyloidosis, SLE. So these causes you people will have to memorize, rattle off in no time. Recall all this. There is a glomerular cause, which is mainly albumin, tubular protein, which can be in a case of poisoning, overload proteinuria in a case of Bence protein or myoglobinuria, post-renal failure, when there is an inflammation below the kidney in the ureter or the bladder, or in malignancy. I would like you people to memorize all this now. Sometimes later becomes never. Mercy.